Mark Trail has seconded. All in favor say aye.
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 Opposed? Hearing none, the minutes are approved. With that, we'll move to the next agenda item, and that's the Commissioner's report, and I'll turn it over to Commissioner Berry.
Thank you, Mr. Chairman and members of the board. Thank you all very much for participating today. I have just a brief update, and it is specific to COVID. I wanted to let everyone be aware that our hospital capacity is very limited across the state right now. Governor Kemp and Dr. Toomey have done many press conferences, but I wanted to reiterate their message of doing everything you possibly can to stay away from large groups, continue to wash your hands, wear a mask, and social distance. There's never been a more critical time in our state from a healthcare standpoint of being sensitive to urgent needs of the hospital system as a whole. Everything we can do to try to reduce, even if it's not COVID related, but keeping people away from the hospital so that they can have bed capacity for those that are in most urgent need is extremely helpful. So not just for our board members, but for people that are watching the board meeting, we would really, really appreciate your support in following Governor Kemp and Dr. Toomey's guidance on that. Our department continues to play a support role with helping with staff augmentation. Couldn't be more proud of our team for the work that they're doing 7 days a week to field those requests for staff. We continue to push for more federal money so that we can grow the number of staff that we're assisting with. But we're in a large number of hospitals, a large number of long-term care facilities, and are continuing to track that. And of course, in the work that Melanie and her team are doing with survey work and things like that is critical. Making sure that immediate jeopardies are taken care of along with infectious disease surveys. So we continue to send our team into those hot spots. Can't thank them enough for all of the work that they're doing. And unless there's other questions, that concludes my report, Mr. Chairman. Thank you.
To the board members, do you have any questions or comments for the commissioner, please? Hearing none, we will move into a presentation on the agenda item that we've been asked to take up this morning and consider for final adoption, and that's medical assistance plans, the comprehensive support waiver program, and the new options waiver program. And Lynette Rhodes, Executive Director of Medical Assistance Plans, will make that presentation. Please.
Thank you. Good morning, Chairman Boyd, Commissioner Berry, and board members. Again, thank you for the opportunity to present. Today's presentation is a joint presentation from both the Department of Community Health and the Georgia Department of Behavioral Health and Developmental Disabilities. Ron Wakefield, the Director of Developmental Disability Services, is present and will assist with any questions from the board. He is employed with the Georgia Department of Behavioral Health and Developmental Disabilities. We also have present this morning Catherine Ivey, who is the Deputy Executive Director with the Department of Community Health. Pending final adoption from the board and approval from the Center for Medicare and Medicaid Services, we are proposing to amend the Comprehensive Supports Waiver, also known as the COMP waiver, and the New Options Waiver, also known as the NOW waiver. As previously mentioned, the Comprehensive Supports Waiver and the New Options Waiver programs provide community-based services to individuals with intellectual and/or developmental disabilities. The Comprehensive Supports Waiver and the New Options Waivers are 1915C Medicaid waivers, which must be renewed every 5 years. The Comprehensive Supports Waiver expires on April the 1st of this year and must be renewed.
Lynette,
While the new option,
can I interrupt just one
Yes.
second? If you are
Yes.
a board member, please mute your phone until it's time to vote. Thank you. I apologize,
Thank
Linda. Thank you.
Thank you, Commissioner. While the new options waiver will not expire on the same date, the waiver will also be amended to incorporate the applicable changes. We are proposing the following changes to the Comp and Now programs. We're proposing to allow 2 services that have low utilization to expire. Those 2 services are the Community Guide Services and Natural Support Training. We are proposing to add 1 new service for both the Comp and Now waivers, and that new service is Assistive Technology. We are proposing to increase the rate of 1 service for both the Comp and Now waivers, and that service is Interpreter Services. We are proposing to remove participant direction or self-direction as a service model for 2 services in the Comp and Now waivers, and those services are supported employment and behavior support. And finally, we are proposing to set maximum daily limits for 2 services when provided in the community living settings. This change only applies to the comp waiver. And we're proposing to set maximum daily limits on additional staffing services. This is both basic and enhanced, and skilled nursing services, both RN and LPN services. An opportunity for public comment was held on November the 18th of 2020 at 10:30 a.m. via WebEx. All written comments were due on or before December the 14th of 2020. We received 25 oral comments from family members as well as friends and advocates of the Comp and Now program members. All of the oral comments presented were in opposition to the proposed maximum caps to skilled nursing services and additional staffing. We received 218 written comments, all of which were in opposition to the proposed changes in the comp waiver renewal application. Approximately 126 of those comments were from distinct family households, which included comments from parents of waiver members as well as other family members. Comments were submitted by family members, friends of waiver participants, their families, advocates, providers, and 1 teacher. It should be noted that the written comments were submitted to the Department of Community Health, the Department of Behavioral Health and Developmental Disabilities, individual staff, and board members. Thus, there was duplication. 8 advocacy organizations submitted written comments either individually or as a group. The submissions from the advocacy agencies pointed out concerns about the proposed 16-hour cap to skilled nursing services and the proposed 6-hour cap to additional staffing services in community living support settings. The advocacy submissions also addressed concerns about the elimination of community living support services as an option for people who require more than a total of 12 combined daily hours of community living support services and additional services, and there were concerns expressed about the revised definition of community living support services. I will now address the comments for the proposed changes. I'll start with the Community Guide Services. As previously stated, we are proposing to allow this service to expire due to low utilization. Community Guide Services provide assistance to waiver members in managing self-directed services and responsibilities. We received 1 public comment from 1 family member who was opposed to the elimination of Community Guide Services, stating that it had been most helpful in navigating the self-directed services. In response, the department states as follows. Support coordination and fiscal support service agencies will provide the functions of community guide services. I will pause for any questions from the board regarding this particular comment and the department's response.
Any questions, comments from the board, please, on that area? If not, you may proceed, Lynette. Thank you.
Thank you, Chairman. Next is the natural support training. Again, DCH proposed to allow this service to expire because of low utilization. This service can be alternatively provided through other available waiver services. There was one comment received, and this was one statement received from a family member living in a rural area of Georgia who expressed opposition to the elimination of this service. In response, the department states as follows. Natural support training can be provided through other available waiver services, including nursing services, community living services, and behavior support services. Commissioner and Chairman, I will pause for any questions from the board.
Any questions or comments on this section? Hearing none, you may proceed, Lynette. I'm sorry, did someone have a question? No, hearing none, you may proceed, Lynette. Thank you.
Thank you. The next topic is assistive technology. Again, we are proposing to add assistive technology as a new service to the comp waiver. There was one public comment received, and that was in favor of adding assistive technology. And in response, we appreciate the support and we thank the commenter for their response. I will move on to the next topic, which is the rate increase for interpreter services. DCH proposes to increase the 15-minute unit rate for interpreter services from $19.38 to $23.35 per 15-minute unit. There is no expected fiscal impact. There were no comments submitted or received for this proposed change. I will move on to the next section, which addresses the increase in the eligibility age for waiver admissions. The department proposed to increase the minimum age from age 5 to age 3. There was one comment submitted, and that comment was in opposition to the increase in the minimum age at waiver admission from 3 years to 5 years. In response, the department notes that the proposed change has no impact on current waiver members, as there are no members under age 5 currently. I will pause for any questions from the board.
Mr. Chairman, this is Mr. Trail. I have a question on the previous bullet item on the rate increase. I'm interested. We're raising a rate and there's no fiscal impact. Could you explain a little bit more about that, please?
Sure. And so this ties directly to the decrease in the other services, and I'll allow Catherine to chime in on that as well.
Thank you, Mr. Trail. There is a maximum number of units. There is a maximum cap on the number of units that can be provided in interpreter services, and that has not changed. So despite the fact that the rate has gone up, there's no change to the maximum amount that can be received. Thus, there's no fiscal impact overall.
Thank you. I'm not really sure I follow the logic, but that's okay. We can move on, Mr. Chairman.
Thank you. Go ahead, Lynette.
Okay. Sorry, any questions regarding the age of admission? Okay, moving on. The next topic is the removal of the participant direction service delivery option for behavioral support services. 4 family members submitted comments in opposition to the removal of self-direction as a service delivery option. 1 family member spoke to the challenges in locating enrolled providers in rural areas of Georgia. In response, the department states the following: DBHDD is committed to assigning regional staff and support coordination to assist in locating behavioral support providers in rural areas if the member or family experiences any challenges. I will pause for any questions from the board.
Any questions, comments from the board? Hearing none.
Yes, I'm sorry, Mr. Chairman.
ahead.
This is okay. This is Trail again. Just for clarity then, what the self-direction part is what we're talking about, reducing or eliminating, I believe. The fact that someone else will assist them in finding behavioral health services will still be the case?
Yes, sir. The DBHDD proposes that they will assign staff from the field office or regional field office, as well as support coordinators to assist families in finding services.
Thank you very much. I yield, Mr. Chairman.
Mr. Chairman, this is Russell Crutchfield. I have a question for Catherine or for
Yes,
DBHDD. I'd like to know, and I appreciate that work done by DBHDD and the reassignment of staff. I want to make sure that that work continues, and if that work is altered in any way, that you notify this board immediately that they're not able to meet the needs of the families that this affects to their regional offices. That would be very beneficial, I think, for us to know what's going on and receive updates.
And I'll defer to Ron Wakefield, the Director of Developmental Disability Services. We will certainly, DCH will certainly notify the board if that becomes the case. Mr. Wakefield, do you have any response to that?
Yes, I do, Catherine. Yes, on behalf of DBHDD, we will notify DCH if there are any specific problems that we foresee. And I will also add, we are also working on making sure that if families are working with a specific behavioral professional at this point, that we will also enroll them into our system if they're not previously enrolled.
Okay, thank you so much. I really appreciate it, and I think I can speak on behalf of the board. I really appreciate you promising to work with each family that's affected, if new families coming in, all this, to get them the care that they need. I appreciate that.
So, yeah, Lynette, you may proceed.
Next is the removal of the participant direction services delivery option for supported employment. There were no public comments submitted for this proposed change. I will next move on to the maximum daily limit for additional staffing and for skilled nursing services. We have combined the public comments for these 2 changes due to the significant number of comments received both verbally and written. In total, we received 213 submissions opposed to the reduction in maximum hourly cap. Some of the comments were as follows, and this is a high-level summary. Members were concerned, or responders were concerned, that the freedom of choice of where they live will be taken away. Other comments reflected that the individuals who utilize this waiver are forced to relocate to group living or roommate living, which is considered detrimental to their own health or those who they live with. There were additional comments indicating that the members were not good candidates for group home settings, and that all of the group homes that they have previously applied for were told that they were not good settings and that they could not guarantee that the group home setting could meet their physical and safety needs. There were concerns that the individuals and the families would have little to no control in a, in a CRA or host home environment. There were concerns from many of the parents that they are in their 80s and older and unable to care for their children or siblings. There were concerns that the most vulnerable people deserve to make life choices and to thrive in their own homes. That is a high-level summary of the 213 comments that we received. In response, we state as follows. DCH and DBHDD are proposing the following exception criteria to the service limits for additional staffing and skilled nursing services. The proposed exception criteria will respond to most, if not all, of the member descriptions submitted through public comment. I did want to take a moment to walk through the proposed exception criteria. There are 4 particular criteria that will be incorporated into the waiver amendment. The first is that a waiver individual has an active criminal court order which requires specific staffing requirements beyond the scope of traditional CLS, CRA, CAG services. The second is that the waiver individual has transitioned from an intermediary care facility or other institution within the past 6 months, and clinically assessed transition needs necessitate additional staffing. The third is that the waiver individual is in the process of transitioning from a crisis home or other crisis setting and has an assessed need for additional staffing for whom CRA placement is not available. And fourth, the waiver individual has a documented history of being incapable of living with others due to challenging behaviors that present significant risk to himself, herself, or others, as validated by a DBHDD clinical assessment. In walking through the criteria, particularly drawing your attention to criteria number 4, again, who is an individual who has a documented history of being incapable of living with others due to challenging behaviors, we feel that this particular criteria is going to meet the need of many of the individuals who will be impacted by this change. So I will pause now for any questions from the board.
Mr. Chairman, this is Mark Trail. I do have actually 4 questions, if I might.
Go ahead.
Okay, first of all, the tool that we use to determine level of need is actually not a new tool. Is that correct? The HRST and the SIS, I believe it is.
That is correct. And I'm going to defer to Ron to respond to these questions.
Okay. Well, I think just an affirmative response on that is sufficient at this point. Let me move on to my specific questions, if I could. All right. So specifically, what really is concerning to me about this is, and let me ask the question this way: is there a reason why we don't simply describe the way that folks would get a certain level of service is based on their HRST rather than describing it as a cap with exceptions? The reason I'm concerned about that is given CMS's history of not really allowing exceptions to things. So in general, why did we approach it as a cap with exceptions rather than simply level of care based on medical necessity?
So, Mr. Trail, in terms of choice, which I did hear mentioned earlier, there are choices in terms of living arrangements. And we want to make sure that people are clear in terms of what those options and choices are in terms of your living arrangement based upon their level of need.
Okay, I'm not sure that was responsive to my question. My question is, let me restate it, maybe a little simpler. Why are we imposing a cap as opposed to just leaving the determination of medical necessity being applied and having someone's hours based on whatever their need is?
Oh,
it wasn't really about choice.
I believe I follow. Because the current service, additional staffing that's currently in existence, we realize that just based upon the way we see it's been used, that there will be a challenge in the future in terms of our ability to be able to continue to have that service. So that's why we introduced the cap. And we did that now as opposed to later.
Okay. I will say that doesn't really, it did answer the question, but it doesn't address my concern. So let me go a little bit further about this. You mentioned choice, but actually Georgia, as we know, has a history very specifically, and the Supreme Court has ruled on this already, that we cannot force someone into a more restrictive environment of care simply for either financial or administrative conveniences, or whatever, however we might describe it. So, I mean, that's kind of a core question here. As I look at some of the things that you guys offered in your response to the concerns raised by the public, it was, well, they could go to another level of, they could go to a group home and be okay, et cetera. It seems to me that that sort of a response is in direct opposition to what the Supreme Court has said.
So, Mr. Trail, I can see that that's where a number of people landed. And as Ms. Rhodes outlined, the group that's going to be impacted, we have those exceptions. And I think it's back to your earlier question, where we are at this point, and we are trying to make sure we meet everybody's needs as best as we possibly can. And we will have a period of transition where we will meet with each person and we will work through what their needs are. The other options are, there are a number of folks who will be able to continue in their current living situation. There are others that we're proposing, maybe they could share their living situation. If they live in an apartment or a home by themselves, they could share that with someone else with similar needs. We also have another option, life sharing through host homes, where one or two people can live with a caregiver. And then, of course, you mentioned the final option, which is CRA group home. So all those other options, we don't consider as being more restrictive. What we consider them to be are living options that, based upon somebody's we will determine along with them what's most appropriate for them.
Okay, I have to say, Mr. Chairman, my concerns remain, and I don't know if I have another. Oh, let me ask one other question very quickly. So, if CMS does not allow the exceptions, given their history, what is it that BHDD or DCH is proposing that they would do? They would not eliminate the cap and move forward, or they would still eliminate, have the cap without the exceptions?
Miss Rhodes, I know there was a preliminary conversation with CMS. Is that pertinent to this conversation, you believe?
It is. I'll chime in. Mr. Trail, we have had conversations with CMS about the proposed changes. We actually reached out to them prior to submission of the waiver to talk through the proposed changes. It was actually a recommendation from CMS that we implement what they're calling a soft cap. Again, this was CMS's recommendation to us. We fully vetted and explained to them the concerns and the impact to our members. And so the soft cap, in essence, means that you put a cap in place and allow exceptions. And this is what CMS talked us through during our previous conversations. So in terms of, the concerns about CMS accepting the exceptions, I don't foresee any pushback from them on the exceptions. They may have questions about these 4 specific exceptions, but it is through their recommendation and guidance that we moved in this direction. And I think Catherine Ivy has some things to add as well.
Mr. Trail, I'd like to go back to your previous question about why specifically incorporate a cap or acceptance versus just taking this from the beginning and using your assessments to, in other words, determine who might need this exception or these services greater than 6 hours a day or not. The rationale for that is that, as you well know, all assessments are, none is absolutely precise. And many folks that are currently served in the waiver and will be served in the waiver in the future might meet these criteria based on the HRST and the CIS, but they also might well be able to live with others, either in an independent setting, in an apartment, in their own home with a roommate, which the waiver allows based on shared staffing, or they might be able to live in a group home or a host home. And yet the eligibility criteria for additional staffing is based on these imperfect and imprecise assessments that do in fact find many individuals eligible for more than 6 hours a day. Does that answer your question a little bit?
Well, it provides me more information. Yes, thank you. If I might ask maybe one other question, Mr. Chairman, if I could be indulged a second.
Go ahead.
Okay, so CMS has this waiver as amended from our previous release of the public notice. They have this amended waiver in their hands now. Is that correct?
That's correct. Yes, sir.
Is it technically required by CMS that the DCH board has taken an official approval or disapproval of this waiver for them to proceed with their evaluation of the waiver?
They require us to complete the public notice process, which we have done. They do not require approval from our board.
All right, thank you. I'll yield for the moment, Mr. Chairman.
Thank you. Any other questions, comments? I might make this comment and ask for some response. It's obvious that this is a very, very difficult situation, and for people involved, we recognize and all the input that you have given to us. We've had the opportunities to review that. Since we did the initial public notice, I would appreciate some comments from Lynette or whoever there. What changes and additions and whatever have we done as a result of all this input that we have received? I believe, as I read through it, things like transition periods and some things like this have been added. as a result, I want the people that have taken the time to provide such comprehensive input to this to recognize that those things have not been just put aside. Would you comment on that, please?
Sure. So I will address the transition plan, and I think that's a good segue and a great point. So DBHDD and DCH have had a significant number of meetings and internal discussions regarding the transition plan. So if this waiver is approved by CMS, we will need time, our members will need time to transition and change to different services. So we have proposed a transition period of 24 months. Now, one thing to note here is that in our public notice, we indicated 18 months. We have since had additional discussions with CMS and have broached the subject of moving that to 24 months, 2 years. And so we are going to continue to have additional discussions with CMS. They are aware of the request. And we are actually going to be talking with them, I think, within the next week or so in more detail about our justification for the 24 months. And so DBHDD will designate a utilization manager to assist the regional field office staff to assist individuals in transition planning. For persons who are receiving more than 6 hours daily of additional staffing in their own homes or family-owned homes will be assessed for the presence of the exception criteria that we just discussed. We will speak with family members, we will interview family members or other knowledgeable historians about previous experiences with congregate living arrangements. We will review historical behavior assessments, functional or nursing assessments, and any other related information. Any waiver participant that is found to not meet the criteria will be given an intensive support coordinator to assist with their service plan development and the exploration of all service options. And so, Ron, if there's anything more that you want to add in regards to the transition plan, or if there's anything that I've missed, please chime in.
Lynette, thank you. You stated that very well. And what I'll add is this, that DBHDD is committed during the transition period to work, not just rely on intensive support coordination, but as Ms. Rhodes mentioned, we're going to assign specific individuals from the field office to also work with support coordination, the families and the teams to do a thorough assessment and have conversations before moving forward. So that's our commitment to, as I stated earlier, we will take this on an individual basis and we will walk through the exceptions that were mentioned earlier and walk through the needs, support needs, etc. of each person. So that's our commitment to the group.
Ron, this is Catherine Ivey. May I add something to that may add a little bit of clarification or a little bit more detail that could be helpful?
Please do, Catherine.
Thank you. I'd like to mention to the board the fact that around 2 or 3 years ago, the board approved a new service which is called Shared Community Living Supports. I mentioned that earlier, but I wanted to go into a little bit of detail with regard to the transition plan, because a few years ago, we developed this service that allows 2 members or 3 waiver members to share one staff person. What this allows is it allows a much greater number of hours every day to be provided because several members are actually sharing that staff. Now, we know that that's not always possible, but in order to facilitate that, there was developed a housemate matching tool, and it actually allows 2 people or 3 people or their family members or support staff to be able to fill out preferences, needs, things that might impact whether or not a housemate match arrangement would work or not. That tool will actually help facilitate housemate matching in the cases of individuals who live in a private home or an apartment and would like to simply add another housemate to this living arrangement to be able to continue to stay there, but allow a good relationship to share housing.
Thanks, Catherine.
Thank you.
Thank you for that, those remarks. I have one other thing. I'm assuming that we have looked at and kind of benchmarked what our approach here with other states, surrounding states. Is our approach out of the norm of other states, or are we consistent with what other states, how they approach the same issues?
Chairman Boyd, let me first say that with this service, what we're doing in Georgia in terms of what's been allowed now, it's an exception for other states. So we have more people receiving this type of service than any other state. It's an exception in other states. And we recognize in this state, as to further earlier comments, that there's some individuals, absolutely, that do need to live by themselves. We're not going to change that. What it comes down to is the level of support that they would need. And again, according to the exception, we are still providing an allowance for that.
Thank you. Any other questions, comments? So I'd entertain a motion for adoption, for final adoption.
Mr. Chairman, this is Mark Trail. I'd like to make a motion actually to table our decision on this until we are assured that CMS will indeed allow these exceptions. That's my motion.
There's a motion to table this until we have more clarification from CMS. Am I understanding that correctly, Mark?
Yes, Mr. Chairman.
Is there a second to that?
Crutchfield, second.
Russell Crutchfield has seconded. All in favor, say aye.
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 So there are, I believe, 3 aye votes. Let me call the roll on that so that we get this clear. Roger Folsom, your vote, please.
Aye.
So you're in favor of tabling it?
Yes, sir.
Okay, Russ Childers?
Aye.
Russ Childers in favor of tabling it. Anthony Williamson, please. Mr. Williamson?
Aye.
Mr. Williamson votes aye. Mark Trail and Mr. Crutchfield has voted that way, so Mr. Cruz?
Yeah, I vote aye.
You vote aye. Therefore, the motion will carry, will be tabled until we have more clarification and approval from CMS. Am I stating that correctly?
Yes, Mr. Chairman.
Okay, thank you. That will conclude our vote, and we'll hear back then from Lynette, and Commissioner will hear back from the CMS approval before we take this up again. Okay, very good. Anyone know of any new business that needs to come before the board at this time? I know of none. Again, I add my thanks, and I'm sure for the rest of the board members. the thanks to the many, many people in this department and DCH and all throughout that are working so diligently to deal with the COVID situation that we find ourselves in. Thank you very much. The meeting is adjourned.